Okay, this is Series 1, Understanding the Lingo of Healthcare Reform. We're going to spend a few minutes looking at the new definitions and how those definitions fit in with existing law and look at it from a number of points of view. So here we go. Okay, overview. I'm going to be doing a lot of reading actually in the presentation here, but then I'm going to explain really what these definitions really mean. Okay, the Affordable Care Act's coverage reforms address both employment-based group health plans and individual insurance coverage. New and old terms in healthcare have new meaning under the ACA. This presentation will define the key terms. So there's two things on that slide right there that I think we all need to kind of really get a grasp on. If we haven't already, number one, there's now going to be kind of a blurry line between group health plans, and that includes insured and self-funded plans, but any type of a group health plan, and an individual policy. So that a lot of the terms that apply in healthcare reform are going to apply simultaneously to individual lines as well as to group health lines. The other thing is some of the words that we're looking here, and this part is unfortunate, but the meaning that we've associated with some of these terms hitherto, now they have a new meaning. So it's going to be important that we educate our employer groups as to what these new words mean. Okay, a health plan. Health plan means both health insurance coverage and a group health plan. The term health plan does not include a group health plan or a multiple employer welfare arrangement if the plan or the MIWA is not subject to state insurance regulation under ERISA, and that would be the ERISA preemption clause. A health plan does not include a self-funded employment-based group health plan, okay? A health plan does not include a self-funded employment-based group health plan. So when we see that term, we are not talking about ASO plans. The term health plan generally is used in the ACA when referring to exchange-provided coverage. Now, let's dig a little bit deeper on this one here because we could have some issues that you might be receiving as consultants and advisors to your groups. A health plan, when it says that a health plan under ERISA, well, under ERISA and also under the tax code, a health plan.
Okay.
Okay, somebody's talking here. I'm afraid we're going to have to mute you here. Let's mute everybody, Balan. Thank you. Okay, please, if you can still hear me, go down on that part where you guys were writing before, because I just clicked a button here just to make sure everybody's okay. Tell me if you can hear me right now. Just start clicking and say yes, 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 yes. Yeah, okay, great. On the phone, exactly. That's what we wanted. Now, a health plan under ERISA and under the code includes a 125 plan and all of the different variations of a 125 plan. So in particular, you know, a POP plan, a premium-only plan, or a health FSA, which are really kind of brought out really in the regs under 125, those are health plans. So when you see the word health plan, until we are told otherwise, and we have not been told otherwise at this point, a health plan also means cafeteria plans. Now, it does not mean necessarily in a full cafeteria plan, the options that an employee participant would have to choose under the 125 plan. So if you have some sort of a modular plan or an opt-up or opt-down plan, credit plus, I mean, there's a myriad of variations of those. We're not talking about the benefits in there, but the actual 125 plan itself, if the employee has a choice between taxable cash and a non-taxable benefit, anytime that situation exists, you have a de facto 125 plan. And then you have a de facto health plan, which means that all of the 5,500, the reporting and disclosure under Title I of ERISA, must also apply. Okay, so just when we're talking about medical plans, everybody's clear on that part. But then also as we're going through this, be thinking on how that applies also to the 125 arrangements that so many of our group plans have. Health insurance coverage. Benefits consisting of medical care only, provided directly through insurance or reimbursement or otherwise, and including items and services paid for medical care under any hospital or medical service policy or certificate, hospital or medical service plan contract, oh boys, that is a great sentence, or health maintenance organization, an HMO, contract offered through a health insurance issuer. Okay, well, there you got it. That's pretty much it. But a better way of saying that, and I've had a number of questions from people, there must be some stuff floating around out there that people have asked me, has Section 213D of the Internal Revenue Code been altered? Has it been altered? Because all medical care in a qualified plan, regardless of where that may be, regardless of how it is sanctioned under the code, any type of health insurance or even health care provided through a self-funding arrangement, the types of benefits that can be included in that plan, any health plan, can only be the types of benefits that are specifically listed in Section 213D, capital D, of the Internal Revenue Code. Now, if you're having a hard time sleeping some night, you can just pull that up on the web, look at 213D. It's not a very long section, but it is a laundry list of items that are actual, what's considered health care to get the tax exemption, the tax preferred status to the participant. All right, so that's what that means. So not a really big change in what we're talking about there in terms of health insurance coverage, but remember that it applies to really the things that are in 213D, and that has not been revised. So if you're one of those folks that have heard that it's been changed, it really has not. A group health plan. A group health plan is a welfare plan as described in 3.1 of ERISA that provides medical care services and supplies, DME, durable medical equipment, for employees or their dependents. And that would be as defined under the terms of the plan. Okay, the plan. The plan is the plan document. We still have a plan document. That is still the highest level of authoritative language in a legal sense that exists. And that has not, at least at this point, that has not changed under the Affordable Care Act. A group health plan includes both insured and self-funded arrangements. A health insurance issuer, this would be typically, we would think of this as being an insurance company, and it is. It would also be in a self-funding arrangement. It would be really the stop loss, if there's stop loss on the plan. It would also be technically the TPA itself, which is administering the plan. They're an issuer. So it's an entity that is licensed to engage in business of insurance, and a TPA must be licensed with the state, as everybody knows, as does an insurance company. So those couple entities are licensed by the state, and they are subject to state law that regulates insurance. So we're talking about pure insured stuff there, because otherwise, with the regulation by the state, that would not apply for an ERISA plan, a self-funded plan. Group health insurance market. Health insurance coverage sold to group health plans. The market is divided into large group market and small group market. Okay, those are terms that we've always had. We've bantered those around, as we know. But those have a slightly new meaning now. So here's one of those examples of where the meaning is slightly changed, depending on what state you're in and depending on how your state has defined small and large market. For purposes of an insurance market, A small employer is defined as an employer that employed, on average, at least one but no more than 100 employees on a business day during the preceding calendar year. Okay, let's just stop right there. That's a change, at least in Wisconsin. In Wisconsin, 50 was the number. So a plan that was over 50 would be considered a large employer. Under 50 would be considered a small employer. So that's a subtle change in the definitions that at least we've got to keep ourselves straight on. Now, a state may elect the option of defining a small employer as an employer that employed, on average, at least one but no more than 50 employees beginning on January 1 of 2016. Okay, so the plot thickens a little bit here. So we have a new definition under the ACA that a large employer is 100 plus, under 100, small employer. Now, the state can change those definitions, but they cannot do that until January 1 of 2016. And that's probably seems like light years to you and I from as far as this law is concerned. It's a long ways off, but it's really only 4 years off. Individual health insurance coverage. This is health insurance coverage offered to individuals in the individual market. So these are individual policies. And it does not include short-term limited duration insurance. So those kinds of policies would not be falling under the definition of an individual health insurance. Now, the individual market. This is the market for health insurance coverage offered to individuals other than in connection with a group health plan. Okay, so group, that's really the key, the operative term there. We will not be using the word group when we're talking about individual health plans. We still will, and the law does, in fact, do this, uses the term group health to kind of tie back to the traditional, what we've lived with ever since we've been in this business, and all of us, the employers that are on this call as well, a group health plan, which would be considered an ERISA plan. A health insurance product. Now, we wish that this would be defined, but it actually, that has not been defined for purposes of the Affordable Care Act. What is a health insurance product? However, the Department of Health and Human Services has defined it as a package of benefits that an insurance company or issuer offers that is reported to state regulators in an insurance filing. Not a real clean definition, probably that we would like, but that is the only really kind of clarity that we've gotten so far. All right, we're going to take a quick little stop here now and do a poll here. So try and keep things going here. So my faithful assistant here, because I can't do 5 things at one time. And it should be coming up here in just a second. Okay, so right now you see that what we're doing is we're asking basically what is the size of your plan participant population. And we're going to let this go for about another 20 seconds or so. So far, half of you have voted. We need all you guys to vote so we can get some meaningful numbers. This is a highly statistical, credible poll that we're doing here. Of course, everybody laughs at that. Actually, it's really not. All right, roughly 16% of you have not voted yet. This is quite like the primaries or anything like that, where you have to think about it. It's a pretty easy question. All right, we've just closed that poll, and now let's take a look and see, for everybody to see on this call, what we look like in front of, in terms of. Now, how can we view this? Oh, so you're seeing this. How come I can't see this? All right, so here, 55% of those people on this call have employee populations, so that would be the majority, between 2 and 49. 41% would have an employee population between 50 and 100. 14% are between 200 and 499, so 51. Pardon me, 55 and 14. That would be 69. Yeah, that brings us up to exactly 100. We have nobody over 500, so that's kind of a little tidbit of knowledge there. All right, so let's continue now. We'll have two more polls that we'll be doing here before we end. A grandfathered health plan. A group health plan or individual health insurance coverage. So an individual policy or a group health plan, employer-sponsored, that was in existence on March 23rd of 2010 and that continues to satisfy certain requirements is a grandfathered plan. March 23rd, that's the date that President Obama signed this particular bill into law. And the language at that time, and it still is true today, is that whatever plan, if an employer was offering that to the employees, or an employee had in an individual policy a certain plan design, all the various things that go into actual benefit plan. If that has not changed for that particular employee or for that particular individual in the individual market, then that plan is considered a grandfathered plan. Now, the term grandfathered plan has meaning because there's a lot of things that do not apply to grandfathered plans. But here we are, going on 3 years down the road from when this was signed, and if there was a substantive change in the particular plan, that would tend to trigger that you could lose the status of being a grandfathered health plan. So the plan, number one, was in existence on or before March 23rd, 2010, and it really has not changed. It has not changed substantively, a plan design change I'm talking about. Then it would still maintain its grandfathered status. And there's some benefit depending on where you're coming from and looking at that. But there are many of these things that would not apply to grandfathered plans. Now, from a practical point of view, I'm just guessing, but I would venture to say that a lot of plans have lost their grandfathered status because we all know that health care plans are constantly in a state of flux and constantly responding and reacting to market conditions. So perhaps a lot of employers would like to have kept that, but the market being what it is has forced them, and the costs going up has forced them to maybe change the plan and hence giving up the status of a grandfathered health plan. I just got a note here, and I just want to clarify here that this is not solely the people that are on this particular audience here. This is not solely for people that work in consulting firms or in brokerage firms, but there are many employer clients that are on here. So I just want to make sure that everybody's clear on that. We are aware that there are employers on here. So, okay, essential health benefits. These consist of coverage for items and services in a comprehensive list of categories set forth in the ACA under such terms and conditions as shall be determined by Health and Human Services, the Secretary Sebelius, pursuant to guidelines set forth in the law itself. HHS has not formally defined what will compromise essential health benefits. We're still waiting for that part. We have some guidance on that, but it's not clear, and that's one of the things that we're all kind of waiting for because it's so important. However, it has published a bulletin and a set of FAQs which further expand on issues addressed in the bulletin itself that provides some insight into how this term is likely to be defined. So right now, unfortunately, we would like to know what that is because I know we're getting pretty darn close to the exchanges being kicked in October of this year. Yeah, this year. It's not that far out. We want to know what are the essential benefits that need to be provided. Otherwise, a fine or a penalty would be assessed to the employer. Let me read a little note here that I'm getting here. Okay, we had a question here. It was actually offered up as a comment here. And it says, please clarify that employers with 50 or more employees are considered large employers for purposes of the January 1 of 2014 employer mandates. My understanding of that, and based on what we've already covered, is that that number, in fact, has changed. It is 100, and that number would remain in effect until 2016. That is an old definition, that 50 or more is considered a large employer, 50 or less is small. Under the ACA, for purposes of defining that, it's 100 employees or more is a large employer, and 99 or fewer would be considered a small employer. So that's the comment on that piece. All right, Health and Human Services has indicated that in defining essential benefits, EHB, it will pursue an approach that will. And so here we have kind of, their thinking, at least, that they've has been released, the thought process that they're running through in trying to define a rather ticklish topic, and that's what are the essential health benefits that the law is going to say that at a minimum we have to have these things in a plan for everybody. And the thought process is this: it must encompass the 10 categories of services identified in the statute. Number 2, it must reflect typical employer health benefit plans. Reflect balance among the categories. Balance. Number 4, it must account for diverse health needs across many populations. Number 6, I believe, counting the bullets here, ensure that there are no incentives for coverage decisions, cost sharing, or reimbursement rates to discriminate impermissibly against individuals because of their age, disability, or expected length of life. That particular one is interesting because it kind of goes to back when the debate was happening, even after the law was passed, and where some were of the persuasion that it should be struck down by the Supreme Court. Obviously, this is a very thorny issue. At any given point, roughly half the country loves this law, and half the country hates the law. So I've certainly learned my lesson not to try and even advocate any part of it, because it then sounds like I'm not being objective, so I won't do that. But this goes back to one of the arguments that people were saying, that these death panels and some of the spin that was being put out there in the press. So here's the law. This is the real deal. The essential benefits must ensure that there are no incentives for coverage decisions, number 1, cost sharing, or reimbursement rates to discriminate impermissibly against individuals because of their age. Okay, they can't discriminate against them because of their age, any type of disability that they might have, or, and I think this is an important line, expected length of life. So we're not going to be looking at if my aunt, who's 92 years old, and she is, and she's still going pretty good. Does she have some problems? Yes. This might have a family member like this as well. She need not be afraid that this law is going to, at least officially in the language of the law, ration any care that would adversely affect her. That's good news. The next bullet, ensure compliance with the Mental Health Parity Act and Addiction Equity Act of 2008. Okay, so the Mental Health Parity Act and all those pieces in there, if there's an annual cap or if there's a lifetime cap on the straight medical, it must also apply to to anything deemed mental health, which would be the ICD-9 codes 290.000 through 319.999. Those are the actual set of codes that are considered mental health, and that has to fall into play here. Provide states a role in defining what essential health benefits is. Now that might be part of the reason why this is going a little slow. I mean, I suppose anytime you have a committee and the more people you have involved in a decision, the longer it's going to take. But the law does require that the essential health benefits, as put forth by the Secretary at HHS, gives the states a role in defining what those are. And lastly, on this slide at least, the essential health benefits approach must balance comprehensiveness and affordability for those purchasing coverage. And just to kind of keep you going, let's take another poll here. So we'll bring one up here. This poll is, how would you assess your understanding of Affordable Health Care Act today? So right now, today, how would you assess your understanding of that? So you have it up on your screen now, and go ahead and vote. Okay, 79% of you have voted. 1 in 5 have not. You're thinking, how well you understand this. So how well do you think today, if you were going to have to take a test on this, how would you assess your understanding of the Affordable Health Care Act? Okay, I think everybody that's voted is going to vote, has voted. All right. So you should be able to see this now on your screen. Nobody, I guess I have to put my hand up on that one as well. Nobody completely feels that they completely understand the law. 60% have said, more than half of you, that you somewhat understand the law. 25%, a quarter, 1 in 4, have said that you somewhat misunderstand the law. And then there's 15% of you that completely say, at least from your point of view, you say that you completely misunderstand the law. So interesting points. It is a, don't feel bad, it's a very big law and a lot of stuff to really follow. All right, still talking about essential benefits here, but now we're talking about kind of switching into to benchmarking and some thoughts that HHS has about benchmarking and essential health benefits. HHS intends to propose that essential health benefits will be defined by a benchmark plan selected by each state. Again, this is an option that they're kicking around, and at some point here, hopefully real soon, we're going to have to decide on one of these as a country. The selected benchmark plan would serve as a reference plan, reflecting both the scope of services and any limits offered by a typical employer plan in that state as required by the ACA. Now, this approach is based on the approach established by Congress, and it follows really kind of the process that we as a country together went through in determining benefits for the CHIP plan, the Children's Health Insurance Program. Now, the options for benchmarking that HHS is considering, they've looked at 4 benchmark plan types that exist today for 2014 and 2015. And here's what they are. Number 1 is the largest plan by enrollment in any of the 3 largest small group insurance products in the state's small group market. Okay, that would be one benchmark that we could look at and say, okay, this is a plan that we're going to use as our standard in determining the essential benefits under the ACA. A second option to look at is any of the largest 3 state employee health benefit plans based upon enrollment. Based upon enrollment. Okay, that's a valid, another way you could look at it. Number 3, in terms of benefit benchmark options, is any of the largest 3 national federal employee health benefit program plans, the options that federal employees have in those plans based upon enrollment. Okay, so that using the federal health benefit plan as a standard. And lastly, number four, the largest insured commercial non-Medicaid HMO operating in the state. So here you have a good dose of managed care being interjected into the plan, more so than you would have with a PPO, obviously with an HMO, and use that as a benchmark to try and establish what essential health benefits mean. Now, the minimum coverage, in terms of the essential coverage, here's how that one rolls. Coverage under specified government programs are included in that. Also included is health insurance coverage obtained in the individual market that provides for essential health benefits. So looking at what the individual market offers and provides as far as what in a state, what an individual plan must absolutely include to be authorized by the insurance commissioner in that particular state. Number three, health insurance coverage obtained in the small group market that provides for EHB. Same concept, but looking at now a small group plan that is authorized by the insurance commissioners of the states and saying we're going to use that as an option or a benchmark. Health insurance coverage obtained in the large group market. Okay, that would, again, under ACA's definitions, that would be 100 plus. Grandfathered health plan coverage, whether or not it is provided through health insurance coverage. Grandfathered health plan coverage, whether or not it is provided through health insurance coverage. And lastly, coverage under a governmental plan, whether or not it is provided through health insurance coverage. So as you can see, my friends, there are a number of options that the government has put out there, tried to look at. It doesn't sound like there's really any one lobbying for any particular piece here. There's a lot of things they're looking at, and I think it's probably a healthy exercise. I hope you would agree on that. Okay, an exchange plan. An exchange plan is a qualified plan under the tax code and ERISA. Okay, let's think about that for a minute. So if you have we're later on in 2013, and we have defined what the essential health benefits that will be offered to all Americans, because everybody's under the individual mandate will have to have a plan. Well, what are the essential benefit provisions that are going to be covered in that plan? The essential pieces, what are they? Whatever those are, that's going to then be put into this new concept of something called an exchange plan. And the exchange plan, obviously being one that's offered through the exchange, will include the essential health benefits that as of yet are to be determined. And the regs are that HHS has put out are saying that will actually be called an exchange plan. It's got a name, just so we just don't know what's going to be in it yet. But it will be a qualified plan, so it'll have all that the tax preferredness that we've all enjoyed since 1942 when group health plans really got their start in World War II. So under the tax code and in ERISA, plans that are offered through the exchanges will be qualified plans. A retiree-only plan. States have independent authority to regulate group health insurance issuers. Well, we know that. Anything that has the word insured behind its name or in front of its name, that must be regulated and approved and can be amended by the Commissioner of Insurance in any one of our 50 states. The ACA preamble encourages states to adopt the same position. As a result, it is currently unclear, we don't really know at this point, if retiree-only plans that provide benefits through health insurance or that are offered on a self-funded basis by non-federal governmental employers So they're lopping off the government. They're saying that you guys are not included in this little definition here. Will be required by one or more states to conform such coverage to the requirements of Parts A and C of Title I of the Affordable Care Act. Now, we all know that retiree-only plans, retiree health care, has been something that, because of the cost, many companies have simply, it's been on the wane. And it's also one of those areas that when we talk about the debt and the deficits that we're running as a country, that politicians of any stripe have been reluctant to really deal with. But it is something, particularly because it's in a lot of collective bargaining agreements. And we all know, because of some of the problems that we've had in some of the states, not the least of which is Wisconsin, that it is a political hot potato to deal with these kind of things. So we haven't dealt with it yet, so they're probably safe to say that there's a fight coming over how we're going to define that. But right now it is unclear in terms of how retiree-only plans are going to be dealt with in the Affordable Care Act. All right, the Uniform Glossary of Terms. This is something that usually when you see this particular term, it's usually read in conjunction with the Summary of Benefit Coverages, the SBC, the Summary of Benefit Coverages. The Summary of Benefit Coverages, well, let's deal with that in just a second, and we'll look at the glossary. The Health and Human Services is of the belief, and probably this is right on the money, that a lot of employees do not adequately understand their health benefits. One could argue that they don't understand hardly any of their benefits as much as they could. Certainly in the retirement area, that's been a real problem. So there's a real dearth of education, despite as much as so many people are trying to do. The populace out there still does really not have a real good literacy when it comes to employee benefits, how to use them, what the terms are, and admittedly it's getting more complex by the day. So HHS has said, okay, we're going to give you a summary of benefit coverages that is kind of like a summary plan description. In fact, it has overlap with an SPD, but it's not an SPD, nor is an SPD a summary of benefit coverage. They are now two things as we speak, two things that basically achieve the same goal, which is to summarize in terms that the average plan participant can understand the benefits that are in this particular plan we are offering to employees. That's what an SPD is. That's the language from an SPD, and that's basically the concept, the thinking behind the SBC. To be coupled with that is this, basically the lexicon of benefits, health benefits under the Affordable Care Act, and that's this uniform, uniform glossary of terms. So each plan participant will have to receive an SBC, and concurrent with that, this uniform glossary of terms. Let's read through this really quickly together. The glossary provides standard definitions of certain health coverage-related terms and medical terms in accordance with the PHSA, the Public Health Services Act. The Uniform Glossary was developed by Health and Human Services and related agencies in consultation with the National Association of Insurance Commissioners. Okay, that's the entity that really is made up of all the various commissioners in the different states that we have. And it was done so to provide generalized, plain English definitions, no offense against lawyers, but we don't want real heavy legal language. We're trying to get back to that with this glossary of terms, the concept that was originally written to ERISA for SPDs, and that it's terms that the average plan participant can understand, plain English definitions, to help consumers understand the basics of insurance, not the advanced concepts, just the basic stuff. The final regulations direct a plan or an issuer, a company, insurance company, to make the uniform glossary available upon request within 7 business days. A plan or issuer satisfies this requirement by providing, 1, a summary of benefits coverage, which is we've already talked about, 2, an internet address, a URL, where an individual may review and obtain the uniform glossary. So really this is not going to be something that we're going to be putting out in paper form. You can, but they're clearly a shot over the bow here to say, well, put this stuff on the internet here, and let's use technology. So it does mandate that you have to have this information available on the internet. A telephone number to obtain a paper copy of the uniform glossary. So this kind of parallels the language with the plan document on any kind of a benefit plan, an ERISA plan. You do not have to offer to give a plan document to any plan participant. However, if anybody wants a copy, they can come to your office and say, I would like a copy of the plan document, and you cannot refuse them a copy. But what you can do is charge them a reasonable rate for actually making the physical copy on the copying machine. That's what you can do. And that's kind of what they're saying here. So there has to be lingo in there for the plan participant to get a paper copy of the uniform glossary. And then lastly, how they can get a disclosure that the paper copies are available upon request. So that has to be out there, that, you know, we do have these paper copies, they're available upon request, but unless you ask for them, we're not going to provide them to everybody. And that's a good shot at most of the key glossary terms that are in the Affordable Care Act. And hopefully all of you were on at the very beginning where you saw word. From now, we're going to get into some of the more technical pieces here. And what I'd like to do is just kind of bring that up again. So as we look at this here, the next topic that we're going to undertake, we tried to give some kind of catchy names to this here. So it's not your grandfather's plan anymore. Healthcare reform exemptions. So there are various plans and entities that have been granted a waiver. Most of them are temporary, or at least they're limited in terms of time, for complying with the Affordable Care Act. Specifically, we're going to look at, and this will be on January 30th, the very tail end of this month, what changes would revoke grandfather status specifically? What are the things that will kill a plan's grandfather status? Number 2, transitional rules to prepare grandfathered plans for 2014. So if you have a grandfathered plan, you definitely want to be able to learn about that piece. Insight on collective bargaining plans. What needs need to be done to retiree only plans to make them viable under this new law, and how to claim accepted benefits properly. So that's what we're going to be covering, and as you can see, the list looks pretty heavy here, but we're going to put it in the nice bite-sized chunks and make it easy for everyone to understand. So at this point, what I'm going to do is ask if there are any questions, and we're going to start by looking at the audio piece here. So raise your hand if you have a question, and or maybe you've already done, and what I'll do is I'll call upon you. Okay, Nika, I see that you raised your hand, but I noticed that your hand was up for a long time, and your phone no longer is working. So I'm afraid that I can't take you live. Okay, those were the questions that were, or there were hands up. Let's take a look at the written questions here. Okay, bear with me just a second, because a lot of this stuff is just people talking about the audio part. Okay, there's Whitney, you put a question here. It says, are you saying that an exchange plan or a private health plan is subject to ERISA? Yes, I am. Actually, ERISA, unless it is amended, ERISA right in the very beginning of the law says that ERISA applies to all employee benefit plans, all. And then it backs out of that by saying some things that are not ERISA plans, like, for example, workers' comp. Disability plans are not, at least short-term disability, is not considered to be an ERISA plan. So there are some exceptions actually in that old law from 1974, ERISA, that says that. Let's see if we have any other questions here. Okay, one last pass here in terms of see if anybody's got their hand up. And nobody's got their hand up, so I want to thank you for letting me bend your ear. Hopefully you found this helpful. Please fill out the evaluations. A couple of things just to think about. This is a baseline piece that we've done today. And I understand that a lot of you know this, but we're trying to build the whole law from an educational point of view, from the ground up. So we're not going to assume that anybody knows really anything, and yet we know that a lot of people probably know just about everything on this. But this is something that we're going to be covering and make sure that everybody really has a good grasp on this. We've compiled some terrific resources that are all very current, and we'll be sharing those with you. I do see one other hand popped up here. Let's see. Whitney, I'm sorry, but you did not enter a PIN number, so I cannot call upon you. So I want to thank you again. Please fill out the evaluation, and we'll look forward to hosting you on the next one, and perhaps all of these. We'd like to have you on there. And be sure to share this with anybody you think might have an interest in this. Share the invitation with them. Thank you, everybody, and have yourself a good day. Bye-bye.